almost pulled up. I saw it briefly. There we go. Okay. So I'm going to talk, I'm a little bit going to lump in early melanoma and melanoma in situ here, but there's been such an explosion of AI and technologies to help us diagnose melanoma earlier or help us with making decisions about what lesions to biopsy. So I wanted to focus a little bit on what impact might this have on the diagnosis rate of things like melanoma in situ, and also how is the way that we've gone about thinking about validating these tools and examining them and even training them being impacted by melanoma in situ and thin melanoma. So, we have certainly, I think most of us have gone through our career with certain assumptions that, we've talked about this, that we've always assumed that melanoma can be detected early and maybe even better with technologies, and that was, something that sort of drove me earlier in my career, and that making the assumption that melanoma can progress from detectable but curable to a fatal stage if we don't actually find it and remove it. And so, we have reached the conclusion without a lot of data that anything we can do to increase early detection will result in reduced melanoma mortality, morbidity, and treatment costs. And my two colleagues have probably convinced you now that that isn't exactly the case, so now I'm going to move on and talk a little bit about technologies. So when we're making decisions about which pigmented lesions to biopsy, it's still hard, and it's still hard for me after 23 years in practice. So there are two lesions here. One's a melanoma, one is not. They look awfully similar to the naked eye. With dermoscopy, we'd probably get some more clues. But again, realize dermoscopy is something that requires training, and if we think about, for example, where do most patients present, it's oftentimes to primary care physicians who do not have access to or training to use dermoscopy. So oftentimes you're just left with looking at this lesion. Also, both of the lesions on the bottom are melanomas. One of them, we do not need any tools to help us with. The other one, maybe one of the ones that we would classify now as being overdiagnosed based on its small size and regular appearance. But these were both melanomas, so this can be hard, again, to make those decisions. So how good are we at making biopsy decisions? We can look at this through reader studies, which would suggest that depending on, I would say, the complexity of the data set, our sensitivity may be as low as 63% or as high as 97%. And Kelly Nelson did this review a few years ago looking at the number needed to biopsy to find one melanoma, and the mean was about 13 for US dermatology practitioners. If you looked at people who were, world-renowned dermoscopists, it was oftentimes 2 or 2.5 lesions per melanoma, and if you looked at people who were not using dermoscopy, and particularly in the primary care setting, it could be as high as 30. Okay, so this kind of brings up the idea then, all right, well, what if we can combine both expertise and advanced technologies? And this was a paper that came out in 21, and I was asked to write an editorial on it, and this has really made me think a lot about, how are we, with expertise, with technologies, and with even our greatest experts, are we able to impact melanoma mortality basically through early detection? And so this was a study, and if you look at the authors here, this is like a who's who in Australia of all the people who have written the texts on screening and on dermoscopy. So this is a very accomplished group of physicians. And so they followed 593 high-risk patients for about 3 years. They had a skin check every 6 months with total body photography, with dermoscopy, and not just, dermoscopy of suspicious lesions, but serial digital dermatoscopic imaging for most of the lesions that ended up being biopsied. There were 171 melanomas diagnosed in this group in 3 years. I mean, that's just really, phenomenal when you think about it. Most of these were actually done not just with the expertise of the physician with their dermatoscope, but actually with the aid of tools including serial imaging, serial digital dermoscopy, identifying very subtle changes, And 68% of those melanomas were melanoma in situ. So, we know that about half of all melanomas that we biopsy as dermatologists come back as melanoma in situ, but, by augmenting this with technology, that went up to 68%. So, my first thought in writing this editorial was, gosh, are we really driving over diagnosis by using these tools? But the second thing that when I was going through all the data and looking at it, I thought, all right, well, maybe we are, but, are we saving lives? I mean, these are high-risk patients, so maybe we can tolerate that if we're preventing them from having thick melanomas. And what was kind of staggering to me was that with this level of intense scrutiny and use of technology, there were still 10 melanomas that were 0.8 to 1 millimeter. That was 5.8% of them. And there were 7 that were thicker than a millimeter. So this has really stuck with me that I don't know that we can use screening and technology to really screen our way out of finding thicker melanoma, or out of the thicker melanomas. Okay. So I'm going to move on and talk a little bit more about some of the technologies that are out there. And also, I just want to think about it in this session about, in the framework of what we're talking about and, thin melanoma in particular. So I think one, as we look at technologies, we ought to think about which lesions do we want to identify. So, do we want tools? I think we would probably say yes, we want tools that are able to identify invasive melanoma. I think that the question is, how important is it to have a high sensitivity for melanoma in situ? And then what about things like severely dysplastic nevi? I think most of us in this room and looking at the data over time would say, we don't really want technologies that do that. However, when you look at how the FDA reviews tools, they actually ask companies to consider nevi with, severely dysplastic nevi, whatever terminology you like to use, to lump those in as positive cases and to have tools that will identify all severely dysplastic nevi. So you can imagine that is going to drive down specificity. If you are trying to find every dysplastic nevus, you're also going to find every melanoma in situ as well as every invasive melanoma. And then I think, non-melanoma skin cancers are another thing to consider. Do we need tools that are going to be sensitive for this? Because if so, if the broader of the lesions we are trying to identify, it's going to also mean that we're going to find, it's going to lower specificity. Okay, it's also going to be important to think about who is using these. So something in the hands of a dermatologist is probably going to be different than something that maybe sits in a pharmacy with a pharmacy technician using it as initial screening device. And this is true, or a primary care physician, for example. And of course, patient-facing tools, we're probably going to need to have different sensitivities and specificities for. Okay, and then why are we doing this? So I think when I started all of this, I thought, well, clearly we're doing this to find more melanomas. But now I'm really starting to think we should be doing this to see if we can do fewer biopsies. And then the other thing is, we are doing these on patients who are, of course, awake and participating and making shared decision-making, with us. And so how do our patients want us to use these? And I think that this is something we need to think about, because if you ask a patient, they will tell you they want this tool to find every potential melanoma. They're probably less concerned with us using it to do fewer biopsies. So we currently have, I'd say 3 tools that are available to us right now at the lesion level. This is Nevisense on the left. This is an FDA-approved tool. This is and this is FDA-approved for use by dermatologists. We have DermaSensor, which is FDA-cleared. And this is for use in patients 40 and older by primary care physicians. And then we have this DermTech pigmented lesion assay, which is actually still available. And this is not regulated by the FDA at all. This is just performed in a CLIA-certified lab. So this is sort of the registrational study for this electrical impedance spectroscopy device. Nevisense has a very high sensitivity for melanoma, 96.6%, specificity of 34%. You can see positive and negative predictive values, and then sensitivity for keratinocyte carcinomas of 100%. So, this is kind of an older study. This is, though, what we can see. We could see it does give us additional data. It is a score. The lower the score, the more likely the lesion is benign. And then for, looking at T3, T4 melanomas, these had much higher scores than, for example, melanomas in situ. So, in using these tools, if you're just getting a high-risk, low-risk answer, you're going to end up bringing in all the dysplastic nevi and, in situ melanomas as well. But tools like this that at least give a score, there is some ability to, consider that something that has a score of 10 is probably an invasive melanoma, whereas, potentially something, as you can see, severely dysplastic nevi and melanoma in situ have very similar scores. It's really a matter of setting the threshold of how concerned to be. This was a study that was done using this as an adjunct to telemedicine. So, and this was done at NYU. They basically invited a bunch of patients, I think 375, who had a lesion of concern, said, come in and, Arm A is we're going to look at the patient and we're going to say, should we do a biopsy and then look at the skin cancers that were that came out of this, that were identified. And then Arm B was each patient went through each arm. In Arm B, they just took images and then had a teledermatologist read them, and they made the same biopsy recommendations. They made their biopsy recommendations. And then in Arm C, they had the teledermoscopist get the EIS score from Nevisense. So what can we see happened here? We can see with each level of kind of separation and bringing in technology, and specifically adding Nevisense to it, you went from a biopsy recommendation of 36 from face-to-face evaluation, 43 in telemed, up to 74 biopsies being performed. Now, there was one additional melanoma that was identified in the face-to-face visit and picked up by Nevisense, but was missed in the telemed. And so, there were only 2 melanomas in this. This is the one that was identified by all groups, so probably something that is a pretty obvious. This was an invasive melanoma. This is one melanoma in situ that was identified using technology. So, again, realizing this increased the sensitivity, but at the cost of doubling the number of skin biopsies that were done. This is DermaSensor. This is this newly FDA-cleared device. It uses elastic scattering spectroscopy. This is the data from their registrational study, and so this was tested in over 1,000 patients. And if we kind of focus on the melanocytic lesions, so there were, if you look at the initial tables, it'll say 48 melanomas, but when you go into the paper, it's actually 48 melanocytic high-risk lesions. What does that mean? 19 of these were severely dysplastic nevi, 29 of those were melanoma. And you can see here what they did was they looked at PCPs, decision to biopsy. All of them were ultimately biopsy, but they looked at PCP sensitivity for all skin cancers and for melanoma versus device sensitivity. So you can see the PCP sensitivity to all skin cancers was 83% in this cohort. The device sensitivity was higher, was 95%. However, when we look at specificity, we can see that the specificity of PCPs was about 54% versus it was 20% for the device. Now, the sensitivity for melanoma was 90%. However, I would argue that we actually, by trying to be overly conservative and put dysplastic nevi in there, you actually sort of raise the denominator of melanocytic lesions. And so when you look at the missed melanomas here, it was actually, there are actually 3 missed, I think it's 3 missed invasive melanomas, 1 in situ, and 1 severely dysplastic nevus. So you're actually sort of increasing that diameter, and the lesions that were actually missed were primarily like true melanomas. So there's actually some harm in trying to be overly inclusive in those numbers. So I just will put that out there. And then this was a study that we did when I was at the University of Pittsburgh. We got this device and we just said, what if we use this to pre-screen patients who came in with a lesion of concern looking to see a dermatologist? And so in our cohort, we had 3 true melanomas. We had 9 basal cells, 10 squamous cell carcinomas. And then we compared what did the dermatologist decide to do, and if it was biopsy, what did the pathology show, to what did the device say to do. So interestingly, what we found was that we reassured or monitored 33% of patients, whereas the device only sort of gave the advice to monitor 8%. Now, again, this is using a very conservative threshold of any degree of atypia being, driving biopsy. What we can see is if we are comfortable with, potentially missing some things like non-melanoma skin cancers, we can maintain a relatively good sensitivity while improving that specificity pretty significantly. So, however, this is going to come, that sensitivity does come at the cost of specificity. And again, how is that positive result, which pops up on a screen to the patient, going to impact decision making? I think it's going to be hard to override that and say, I know that it's a positive result, but it's a low score. Let's continue to watch that. I think, it'll be interesting to see how this pans out in real world use. And if patients will use this as a reason to forego referral or biopsy. Okay, this is the DermTech pigment and lesion assay. This just basically is a piece of tape that looks for the presence of one or both genes, which one is a long non-coding link, which is a non-coding RNA, PRAME, which we know is an antigen that's expressed in melanoma. We also know in many other melanocytic types of lesions as well. And so this piece of tape is put over a lesion. It's sent out to the lab. They say either you have, neither gene is present, that's a negative test. Either one or both link or PRAME are present, that's considered a positive test. And in studies, this had a sensitivity of 91% and 70% specificity. I don't know. Should I, what's it? So are we okay to should I just keep going? Keep going, okay. So that's how this looks. So kind of the next part of what I want to talk about is, how does real world performance mirror, clinical trials? So this I thought was interesting. This was a study that was not funded by the company. This was actually Forefront Dermatology. One of the private equity groups, they said, well, we've sent out 893 of these tests. Sometimes, in some patients we've got follow-up, but how did our results compare to the study? And so what they did was if we looked at a positive test was having one or both genes, a negative test was having neither. They found that in their sort of group practice, sensitivity was 92%, which is pretty similar to what's been reported before, and their specificity was 79.5%, which also was kind of similar to what was presented before. So I thought that was interesting. The other real-world study that I thought was interesting here was this is looking at another group in California, and they looked, Brooke Barua was the author, but it was looking across multiple groups that were using the test. So they looked at over 3,400 uses of the test, and 324 of those were positive. So if we look at, and then you can see here the number of benign lesions and melanomas that were identified. So I'm also trying to look at the cost here. And so I'm going to use, $760 as the cost of running the test versus $175 for doing a biopsy just with H&E. So you can see with over 3,400 tests, 316 of the 324 positives were actually biopsied. There were 47 lesions that were melanoma in situ, so we can see the majority of them were benign lesions. 47 were melanoma in situ, 11 were T1As, and 1 was a T2A. So, what does this mean? Using this technology, you had to run over 3,400 tests, to find these 59 melanomas. So number needed to treat to find a melanoma, 58, cost $44,000. If you said, all right, well, what's the cost just to find the invasive melanomas? That is, number needed to test was $285 to find one of those at a cost of $216,000. And then to find that one T2 melanoma, which is probably the one that has the greatest, potential to cause death, is $2.6 million, are testing 3,418 lesions. So it's important to think about these things. Okay, so I have now kind of tried to think a little bit differently about, how I use these tests and how I talk to other people about using these tests. And instead of just thinking about sensitivity and specificity and positive and negative predictive value, I like thinking about this in terms of likelihood ratios, because when you're thinking in terms of likelihood ratios, that means that your pre-test odds of something being melanoma come into play are important. So a likelihood ratio positive is when you're using something as a rule-in test. So if I said with a positive test, how much more likely is it that this lesion is melanoma? So, this is, you can see the math of, the sensitivity over 1 minus specificity. And if you use a likelihood ratio negative, it's, thinking about this as using it as a rule-out test. So if this test is negative, how much less likely is it that this is melanoma? So this is, you can see the sensitivity and specificity and how they go into that. So if I just take from, these different devices or tests, if I use the sensitivity and publish specificity and calculate a likelihood ratio of positive and negative for each device or tool, I think you can see that one, they're probably better rule-out tests than rule-in tests, right? And then, you really want to think about your post-test odds. So after I get that result back, what are the odds now that this is a melanoma? And that's going to depend on your pre-test odds and your likelihood ratio. So, one, I think before we use these tests, we should think, what is, in my mind, is the likelihood or probability that this is going to be a melanoma? That's going to depend on, it's going to be different for me than it will be for a primary care physician. And so I think that's why it's important to think about who's using these. And then if you said, all right, there's a 1% chance I'm going to do this test, if you do it and you get a positive result, and your likelihood ratio positive is now 1.5, does a 1.5% odds sway you any more than a 1% odds? Now, where this could be useful is, what if you said, I think the odds that this is melanoma is about 20%, right? So, but maybe I don't want to have to do a biopsy in this patient. If you get a negative test, and this has a likelihood ratio negative 0.1, a 2% odds in the right patient, in the right setting, may sway you not to do a biopsy. So, I think it's important to really think about this before we're doing these, and not use tools to find melanomas that we would have never biopsied before, but to think about them more as ways to de-escalate biopsy. And, this is sort of looking at, I did participate in some of these DermTech studies. So, just looking across the results, this first study was done by me and Padram Garami, who's also a dermatologist and dermatopathologist. He's a very world-renowned pigmented lesions expert. So, we were running high-risk specialized clinics. We evaluated this in 200 patients in whom we had already made a decision to do a biopsy. And overall, 27% of our tests were positive, and the percent of our positive tests that were melanoma was 35%. So I look at this as this result would have informed me, did I have to biopsy it? Could I have avoided biopsy in some of these patients? Sensitivity in our lesions was a little under 90%. In another registry study done in more of a primary, a community dermatology setting, you can see that they did over 3,400 tests. Only 10% of those were positive, and of those positives, 19% were melanoma. And then in a second registry, pretty similar numbers. They were two slightly different versions of that test. But I suspect that in that real-world setting, they were using this a little bit more in the, maybe I could watch this, but I'll just run a test and see if I could biopsy. So I think they were using this more to say, should I do the biopsy versus should I not? And you can see that that impacts test rate positivity. This is another kind of interesting tool. This is one that is being used in the National Health Service right now. And so it is basically using AI reading dermatoscopic images to say, can we triage patients? Can we triage lesions that are referred? Now, what's interesting is that you can see that what it does is it first says, is this a melanoma? Yes, you're triaged. And it goes down the list to least severe things, down to atypical nevi or benign. benign. However, the GP referral threshold is set at anything that triggers as being an atypical nevus or beyond. So, again, while this is actually being deployed, I think it's going to be really interesting to see how much it is able to avoid referrals. And this is looking at, I'll just show you quickly, data from one of their studies where they looked at use across a couple different centers, and you can see that when every lesion was actually, evaluated by a dermatologist, that the sensitivity for melanoma or all skin cancer was high, and the specificity was not bad as well. When they did look at this study and they said, let me look in these two settings. On the right, on both ones, are lesions that were assessed by the tool. On the left were lesions where they didn't use the tool, they just went through the standard referral pathway. This tool was able to actually say you don't discharge patients in 25 to 40%, depending on which group you used. And then when they did go back and review those cases, none of them were skin cancer. In the ones that were reviewed, there were more skin cancers, so higher positive predictive value. So potentially that does help, with sort of triaging referrals. Whereas without having any sort of triage, the majority of the lesions, there were much lower prevalence of skin cancer and melanoma. So what I want to kind of end on is, these are interesting technologies for looking at single lesions, but, what about looking at whole body imaging? And, as we're talking about what are lesions that are indolent, and we saw examples of lesions that change very, very slowly, can we use AI to basically help us to quantify change? Because we know that, change is the definition of growth, which is the definition of cancer. So, many of us have for years used these serial images. Now there are these tools that can actually, help us to not just, map patients, but also have technology that finds lesions that are new and changing. We did have one randomized controlled trial that interestingly did not show what we thought it would show. So what they did was there was a group who had serial imaging with the Vectra system, which was the 3D total body photography system, and then another group that just had routine exams by physicians. And so what we can see here is sort of the opposite of what they thought they would see, that there were actually more melanomas identified without technology, similar number of melanomas in situ, more keratinocyte carcinomas identified, but also just way more skin biopsies of benign lesions in the intervention group as well. So this was, I think, partly a unfortunate aspect of the study design, that you had more benign lesions and fewer melanomas, but there was more scrutiny. There's more scrutiny applied in the intervention arm, and it was done during COVID. So I think we're going to I'm not going to let that be the jury is out on using 3D photography. This is another study that I thought was interesting, which used, specialized imaging in centers in Germany. And so they looked at patients who had imaging consultation visits and just routine outpatient, a dermatologist with a dermatoscope is the routine care. Imaging consultation is you also have digital dermoscopy and 3D total body photography. They kind of saw the opposite with imaging consultation. They found that there were more melanomas, and in particular more invasive melanomas when you use things like 3D photography to help you identify changing lesions, and a similar number of in situ melanomas, but far fewer biopsies of benign nevi, and that the number needed to excise went down dramatically, like oftentimes 10 or more fold, by using imaging. So I'm hopeful that this is going to be a way to help us find the important melanomas, which are the invasive ones, and hopefully limit the number of benign nevi. Okay, so I think this could also help us as dermatologists. Our time is an important resource. We spend a lot of time physically examining the patient to just weed out the multiple benign moles to see if we can figure out which ones we need to focus on. So looking at these different technologies, this is one that compared 3D and 2D imaging. Well, you could the black dots are melanoma, and that's sort of like the highlight of the results here. What I thought was really interesting is these are all the benign lesions. So maybe instead of thinking about these as technologies to pluck out all of the melanomas, what if we say, many of these tools are really great at saying what we don't need to worry about. So I am now trying to think about this as, can I just figure out pluck out the benign ones, and then I can spend my time on the fewer suspicious ones. This was another study that was done actually with Memorial Sloan Kettering. You can see these are all patients who had, imaging with the vector system, which does give an AI readout and ranks lesions from most to least suspicious. These are all the patients who had at least one melanoma, which is the red lesion. And if you look at the severity score, you can see that the vast majority of them are the patient's most suspicious lesions. So what if you said, I don't even have to, look at below this threshold or below this one? It turns out that 28% of melanomas were the highest scoring lesion. Over half of them were in the top 99 percentile, and 79% were in the top 95th percentile. So even if we could just examine 95% fewer lesions, we could probably really, have an impact on access. Okay, so this is, something that I thought was interesting is, we're one of the only specialties that finds cancer by having a physician look at every inch of the patient. So, in breast cancer, like we don't examine patients' breasts. We send them to a place where they can get a mammogram, a radiologist looks at the film, and then they come face to face with a clinician when there's a lesion of concern. Prostate cancer, same thing. We order a blood test. You only come face to face with the urologist when you need a biopsy. And so potentially, maybe with imaging, we could do this as well. I'm going to skip over my cost stuff, but one of the reasons, basically, that we did this study in Pittsburgh, one of the reasons to avoid a lot of face-to-face visit is that we spend a lot of money doing low-value care, doing things like freezing seborrheic keratoses or, even actinic keratoses, and a lot of the cost of melanoma diagnosis is actually caught up in the cost of sort of treating the other incidental things that the patient comes in to see us for. So there are a couple companies that are looking at this. This is one called SkinBit, where they say, we could have the patient, we could be in a mall, the patient would go in, they would get their full body imaging, that could be remotely reviewed, and then we'd only have urgent referrals or referrals for lesions that are truly of concern to dermatologists that this could help with access. This is another one, just I put in a few different companies, Lumo Scanner. Essentially, that does the same thing and then even can look up, it so closely as to get dermoscopy-like images, which could then go through things like, 7-point checklists. And so we could apply AI to having, the most suspicious lesions identified too. And then this is one of my favorite ones, which is this robot that essentially could go up and down the patient, photograph every lesion, get dermatoscopic images that were actually in this study in JAMA Derm so high quality that the dermatologists who read one lesion that was the same lesion acquired by this device and another one and by a traditional contact dermatoscope, they couldn't, they couldn't tell the difference. So this would actually be a way to get sort of that full body imaging. So I think that there's a lot of kind of interesting ways that we can think about technology. I think one of the important things that we're gonna need to think about though is what is the endpoint that we are looking for? And how, what is the study design? So are we looking for all sensitivity to for all melanomas or for all skin cancers? Are we looking at sensitivity similar to a dermatologist? Is our endpoint, treatment cost? Is it detection rate? Is it melanoma-specific survival? And I think we don't really have the answer for all of these yet. So, in conclusion, I think, we want to make sure that when we're using technologies that we're not just thinking about detection. I think we want to be making sure that we are being very aware to minimize overdiagnosis, that we are focusing on identifying potentially lethal melanomas, that we are using these to identify stable indolent lesions that, regardless of what they might show histologically, probably don't need to be removed. Somebody who practices in a very rural state, I think we need to make sure that we are not doing this at the cost of access. So the more time that we spend with very intricate exams and lots of tools at the bedside is just going to hurt access. And And then I think we ought to think about, how we evaluate, train, and regulate these tools might impact diagnosis as well, particularly including severely dysplastic nevi in both training and validation sets. So thank you very much. Okay.
All right, so we have about 20 minutes for questions. So if anybody has questions that they want to ask, come on up to the mic. And I think we're all kind of gravitating towards the same. I 100% agree that the benign, weeding out the benign is huge. And a lot of the technology that we are doing is doing kind of the same. And I think that it's going to require us to upskill what we do for those select few lesions that remain after. And whatever, ancillary technology and our upskilling together will help, weed out the problem even further.
Yeah, I want to give credit to, so we had a session on this at a meeting, and Henson Tsao got up and he said, the problem, and this is like really just giving me so much clarity, he said, the problem we have with melanoma detection and screening is it's a signal to noise problem. So, right, like if you think about breast cancer, like patients have two breasts, and there are not two breasts that are full of 150 masses and only one of them is the cancer, right? So, like when he said that, I was like, you're right, this is the problem. So let's use technology to help us with the signal to noise.
Michael.
Michael White, live in flyover country out in the Midwest. My nearest neighbor is a quarter-mile away. I live in true rural area. So I comment and a question. I like a lot of the ideas of using technology, particularly when I put it in the hands of NPs and PAs, and I'm one of those guys that works with them, because where I live, a lot of people, if they didn't have an NP or a PA, there would be no health care at all. However, I do live in the country, and the devices and so forth, as being used right now, are not going to be deployed to the country. They're going to be deployed in the big cities where they can do a lot of benefit. But people need to stop talking about rural medicine, because the things that they have there are not going to work in a rural setting. There is a rural care initiative that we're working on right now that may make a difference, putting dermoscopy and tools in the hands of the rural nurse practitioners and PAs. That has promise. The question is, I found the genetic stuff really interesting. So if I follow you correctly, the gain of a BRAF mutation is important, followed by the loss of certain other tumor suppressors. How is that happening? If that's ultraviolet, then I marry that to the distribution of where melanomas happen, which doesn't match the high ultraviolet exposure distribution on the body, and I'm going, wait a minute. It suggests to me that there may be two populations, where one population where these mutations take place are in fact the ultraviolet exposed, and those are the lentigo maligna melanoma in situ kind of tumors, and we may be able to separate out more by looking at the mutations and saying, okay, because of this mutation, this is not likely to be invasive, not likely to progress, and you don't have to do anything.
Yeah, that's a really excellent point. And I think in showing the WHO table, I didn't harp a lot on the very bottom of it that was color-coded, but each of the 9 pathways that they lay out have characteristic mutations that are the beginning and endpoints of those pathways. So, for example, common acquired nevi, which their malignant end of that is what we would normally call a superficial spreading melanoma. Most of those are driven by acquired BRAF V600E mutations. Mucosal melanomas and acral melanomas, they're common drivers, not the most common, but a common driver is KIT mutation, for example, not acquired by UV, right? Not UV driven in either a mucosal site or in the vast majority of true acral lesions, which are palmoplantar or nail. Desmoplastic melanomas oftentimes have knockout of NF1. That's kind of like the seminal driver, and then they lose P53 as like a second event that happens in those, which is interesting because you see desmoplastic melanomas more commonly in patients who have germline NF mutation. And So I think your point is an excellent one. A lot of this work has been hashed out, and so even the morphology of certain lesions, including, I'm thinking Spitz lesions in particular, have so like ALK-driven Spitz nevi and or Spitz melanocytomas, which is the new terminology for an atypical Spitz tumor, those have a particular morphology as opposed to HRAS-driven Spitz nevi, which tend to be the desmoplastic Spitz variants. N-track drivers have a particular morphology. I think I think we're developing the story. It's more complicated than I'm making it sound, but I think that there are characteristic appearances and morphologies of different driver or melanocytic nevi or proliferations that have particular drivers. There's kind of a correlation there. And I think your point is excellent that some of them being UV related, some of them not. Clearly, the lentigo maligna type, that type of melanoma in situ, just has a very different course than what you would see on the chest of a young woman who's newly pregnant, for example, with a changing lesion.
Thank you.
Yes.
Hi, thank you. These were all spectacular talks. I want to go back to the beginning to Dr. Margoob, to your lecture, and the topic of monitoring these lentigo maligna or superficial spreading melanomas, and doing that over years. I'm wondering, when you do get to that case where a lesion develops a small invasive component, how are you managing this excision process at that point? Then do you take out the entire melanoma, or do you just take margins out around that small invasive portion? And how are you navigating that with your teams?
So, excellent. A lot of it depends actually on what the size of the lesion is, right? So a smaller lesion that can easily be removed in its entirety, including the invasive component, we do that. For the larger ones, and for just as an example, I have a patient that I just saw last week who has lentigo maligna we've been following for quite a long time, but it's across her entire upper lip onto the mucosal aspect. It goes onto the gingiva, and so it's completely a non-resectable disease, and she developed just an invasive component in the middle. In the end, on that case, we just remove the invasive component. And then are just monitoring the remainder. So there are times where it's just not an operable disease, but obviously there's an in-between as well. So there are individuals where we won't chase margins, for sure, all right? So we will remove the invasive component, and if the margins are positive in in situ disease, we're still okay with that. We'll offer imiquimod in that scenario. To maybe clean up the remainder. Most patients actually elect for that. So I think it's a case-by-case basis. How easy is it to remove? Can you remove it at all? Is imiquimod come into the play that can help? And active surveillance, in some cases, even after removal of invasive, the patients decide not to have anything else done. We just then continue to monitor the in situ component. So yeah, I think it's case-by-case, but excellent question.
Thank you for all three excellent talks. Just on the topic of lentigo maligna, two questions, if I may. I was wondering if any of the speakers have any experience with other formulations of imiquimod, such as 3.5% or other strengths than the classical 5%. That's one. And the other one is, I suppose it's quite tricky, and you've presented this very eloquently, to say what, when a lentigo maligna progresses to lentigo maligna melanoma, or when it gets upstaged, if initially it was a lentigo maligna melanoma that was missed. Are there any practical tips or pearls that we can take going forward, perhaps in how we conduct our research studies, if we want to look at how lentigo maligna progresses into lentigo maligna melanoma going forward?
So on the first question, so 3.5% versus 5%, I'm not aware of any studies on with 3.5%. So I don't think that all of the data was driven by the whatever's out there is by 5% imiquimod. There are different regimens. I mean, one is use it every day for 3 months, but there are variants of that. But I'm not aware. So I don't. It's an unknown. Will 3.5% work? On the second front, if I understand correctly, is that is to understand the biology better of that, of lentigo maligna. Yeah, I mean, I'd be curious to see what Laura and Atta have to say to that. In my experience, it's about, I mean, again, remember this is spanning a long 35 years. I would say I have a handful of patients that go on to develop an invasive disease, and most of the time, if not all of the times, it's detected by dermoscopic changes that are focal within the lesion. So it's not the entire lesion that changes, it's a focus within, and the common features are going to be shiny white structures, vessels, or blue color, which are all features of invasive disease. In all of the cases, nobody has died yet, meaning they haven't developed metastatic disease and succumbed to it. That's not to say that I haven't seen patients that have developed that, you know, as patients referred to me with lentigo maligna. But in my hands, that has not occurred. But the true biology, I think that's part of what, we are after. And Atta, I know that there was some issue of one paper that said that if you have just lentiginous spread without nesting, that has a better long-term outcome than if you had nesting.
Yes.
And so there may be clues, but maybe, Atta, you could address to that.
I'll try my best. I think it's another one of these questions of, okay, so let me take a step back real quick and draw from the Spitz sort of literature and experience. So true Spitz melanomas in children are extraordinarily rare, right? And if you have a Spitz lesion in an adult, meaning it has a molecularly defined Spitz driver, you also tend to have a much more indolent course, even if it meets criteria for melanoma, than if you had a canonical adult type acquired like BRAF mutation or something else. And so I suspect that whatever driver mutations or collection of weak sort of proliferative indices are present in these lentiginous proliferations, if you add something to tip over some subpopulation of those cells to develop invasion, the fact that your baseline driver is still some like weak growth impulse leads to this very banal and sort of indolent course, as opposed to these pleomorphic melanomas that you get that have some catastrophic genome destruction and TP53 loss and, nodular melanoma, all these other things. I suspect it's just the protoplasm to begin with is weak, so to speak. It's not aggressive. And so I think that's probably accounting for that biology.
And Laura, do you think that we could one day have a in vivo test to look for those, for gene expression? I mean, we know we have DermTech, but going a little bit even further than DermTech.
Yeah, I think like what we have now is not sufficient to do that. But yes, to me, like that makes sense. Like hopefully, we can move to a more like genomic classification of melanoma, right? Like right now we're, everything is like based on visual appearance, right? What does it look like to the naked eye? What does it look like to the under the dermatoscope? What does it look like to the pathologist? And then, if we could really go to like classifying these genetically, it's almost like how, we've done this with some of the epidermal